Yes. Okay, and I
You choose
see
the
my
screen you want to share.
presentation. Got
Just
it.
click on the presentation and share it.
There was a professor it was on the news. There was a
Right.
professor from Duke that shared his screen, and on one of the tabs in the Chrome, he was looking at porn or something. It was even on the
Wait a
news.
second. He couldn't wait.
Exactly.
It's like, okay, that's funny.
All right,
Okay,
now we're recording, all right?
all right, sounds good. Let me just make it a full screen. Okay. So, how do I? You know what? Let me just minimize this. So I can see my full screen. Okay. So today's topic, I'm just going to go back quickly. So today's topic is going to be immediate load. I just kind of throw that topic out, but we're going to kind of deal with multiple issues and things like that, like aesthetic zone. I present, I'm sure you guys have seen a lot of cases of socket shield. We'll talk about socket shield a little bit. And we can keep this light. And if you want to ask a question, you could either send it to me privately, or you could just go ahead and, just unmute yourself and just ask your questions, and we'll stop. So the goal is to kind of be in a relaxed mode, like everybody's in their pajamas right now, and we can go ahead and learn from each other. And if you have any suggestions or whatnot, you can go ahead and just chime in and let me know, and we can discuss it. So okay. So I just want to first of all thank you to UFM, Dr. Kayarga, who asked me to go ahead and give you guys a lecture and to just share some of my cases with you, plus some information that maybe I have, and I can go ahead and talk about it with you guys. So we are in a very crazy time in our lifetime that I don't think anybody imagined that we're going to go ahead and sit like this and in front of a computer and talk to each other and stay away from each other, no handshake, wear a mask, be careful, no social, keep social distancing and whatnot. So this is a very interesting time that I don't think anybody imagined. Just looking at some of these famous areas in the world where, generally speaking, you have, many, many people walking around. Unfortunately, today it's kind of empty, and people are staying home to be safe. So as a result of something like this, as a result of having something like the world is in lockdown, it's not just one country, it's everybody's doing the same thing. So this is a very interesting time to go ahead and be. As a result, I believe the world is slightly smaller than it used to be because of this situation. We're sitting in front of a computer and we're connecting to many, many people like yourselves. You probably got lectures from some of our old students from NYU, from Spain, from Italy, from whatnot, all these locations. So so the world has gone much, much smaller, and even smaller than we used to know it. So just to kind of tell you that I feel a tremendous love from UFM, and it's a second home to me. These are some of the people that work with me and myself, and I just love it every time I come to Guatemala and to UFM, and you guys are absolutely amazing. From people who basically come and maintain the clinic and the floors, and to the assistants, to the residents, to the faculties, and obviously above the dean and everybody else. So I really appreciate it. Thank you very much. So this is like good times. Every time I come there, we really have an amazing time, and we share our knowledge together and we work together, and it's a lot of fun. It's not only work, but I enjoy it, and I love every time I come to Guatemala. So to just let you know, for those of you who are not, you don't know me, you can go ahead and follow these social medias. More importantly, I post a lot of cases on YouTube under that dental implant surgical seminar. And if you are interested to go ahead and see, different videos and different products or whatnot, you are more than welcome to subscribe and look at that, look at those videos. So, as a disclaimer, anything that you see in my lectures, I have no financial gain, or I'm not an investor in any of these companies. These products basically work under my hand, so I just keep on using them. If you want to use them, or if you want to go ahead and know what they are exactly, you could email me, and we can go ahead and discuss it, and we can talk about it, and I can give you the product number or whatnot. But otherwise, as far as everything else is concerned, I have no financial, gain from any of these companies. So the topic that we're going to go ahead and basically discuss today is a little bit of a digital dentistry and computer guided surgery. You guys generally are in good shape, being in UFM, you're state of the art with what you're doing. So this is great. So it might be some redundancy of those informations for you guys. We'll touch upon an aesthetic zone and consideration, in conjunction with immediate load. Immediate load itself, the criterias and the protocols and whatnot. The 3D consideration, some of the treatment planning that I do, and I think, and I process the patients on each particular cases, smaller cases versus larger cases, the clinical protocols, and guided immediate loading as well. And something that's kind of missing here is a socket shield. We'll also kind of try to touch upon that topic as well. So I wanted to go ahead and bring home a interdisciplinary management and the decision process that you have to go ahead and make in your head when you see a patient. I want you to kind of look at certain things, and sometimes we put a grave importance in some aspect that should not get as much importance, and sometimes we completely ignore certain issues that the patients need to go ahead and have, and that's what we're going to go ahead as well discuss. To just put down in a layman's term, today with the implant dentistry, we're talking about two separate phenomena. There's a phenomenon of a function, and then the other one is an aesthetic. Okay. So just to go ahead and tell you, the function, as far as a bodybuilder is concerned, can be thought as a training specific for everyday living. We go to the gym, we work out, we try to stay healthy, we eat well, and that's as far as we're going to go ahead and take it. So that basically is going to go ahead and translate in function in dentistry, as opposed to an aesthetic where it can be thought of as training to make one's body more beautiful. Now, whether you think Arnold Schwarzenegger at this stage in his life was, had a beautiful body or not, but just bringing it down to implant dentistry is today function will not be good enough. And if the function is the only criteria, then in some literature that would be considered as a failure. So when we look at a case that comes into the office, take a look and see immediately as a dentist or even as a layperson, based on a smile line and whatnot that the first thing that you look at, you're looking at that 1/3 of the area of the tooth to the tissue relationship. And you can go ahead and see that there are two different patients. Now, the patient onto the right is my patient. The patient onto the left also is my patient, okay? And take a look at the results that I have. Now, do I consider the patient on the right side of the screen as a failure? I don't know if it's considered as a failure, but it certainly makes me think, what did I do or what didn't I do? Or what criteria I missed or what criteria I should have applied in order for me to get a result like the other side, okay? So the other aspect of what we're gonna go ahead and talk is the technology. Technology today is really unbelievable and what we can go ahead and do with it. We are really in an amazing place in dentistry of what we can go ahead and achieve, as well as what we can go ahead and give to our patient. So the technology, it's best we can go ahead and use that to our advantage to be able to go ahead and produce cases on a previous slide to the left versus the cases to the right. Although biology is going to do what biology does, but the technology is going to come in to help us try to achieve the best result we possibly can achieve. So one of the main questions that everybody asks is implants. What implants should I use? What should I go ahead and buy? What company is the best? I don't think there is a specific answer, because if you look at any implant company, they all get failures. They all have periimplantitis. They all have issues of their own. But one thing I recommend, even as a surgeon who places an implant, you should also consider that one of the most important part of an implant dentistry, obviously, is the prosthetic option of an implant. If you're picking an implant to go ahead and do, and of course for immediate loading, a taper implant will go ahead and give you a better stability at the time of the implant placement and whatnot. There are some advantages on designs, obviously, on the implant based on what you're trying to go ahead and do. If you're doing it posterior, you want to have a wide neck implant, you want to have something with a wide platform. So of course there are certain advantages to the design based on a particular treatment that you are rendering for the patient. But at the end of the day, the ultimate goal of any implant system should be ease of a prosthetic use. If you have an easy prosthetic options or very diverse prosthetic options that you can go ahead and do on those implants, and all of a sudden that implant becomes very attractive, because obviously everybody knows patients come to our offices, or to the university, not because they want to get an implant surgery or they want to get a bone graft. They are coming in because they want teeth. So therefore, if you're choosing an implant system, that implant system should have a very diverse and very strong prosthetic options. So as far as the guided surgery is concerned, where do you begin? Again, as I said, some of this information may be redundant when it comes down to the guided surgery, because you guys in UFM are really doing this, routinely now. But, obviously the patient comes to the office, and then I also wrote a protocol of how to take a Cbcp based on a particular case, whether the patient is completely edentulous, whether the patient is partially edentulous, whether the patient has one number of teeth they have, and how you should go about doing it if you want to create your guide. So obviously, in order for us to go ahead and create a guided surgery, whether you want to do it yourself, whether you want to send it to a company to do it for you, you need the CBCT as well as the STL. So those are the two information that you're going to have, that you're going to merge together and create your guide. Obviously, when it comes down to the STL file, you have your options of intraoral scanner versus a desktop scanner. And you can go ahead and scan. You guys have seen, you have multiple scanners. in UFM, so that should not be an issue. I'm not sure if you guys are doing it routinely on a PROS. I've actually seen some of the PROS students take impression with the intraoral scanner while I was there. So you guys do this routinely, so that should be of no issue. Oops, sorry about that. And then obviously we are, talking about at the end of the day to print the result, plan the case, print your guide. You need a software to be able to go ahead and create your guide, and once you have it on that software, you create a STL file, and then you send it to a 3D printer. Now again, all this can be done if you are interested to do. This is not all or none. I don't want you to think that because I cannot plan it on the computer, because I cannot take an STL file, because I cannot print it in the office, that this is not for you. It's actually not true. You are able to go, and if I don't have a Cbcp in my office, you really do not need this equipment. This equipment is for somebody who is constantly and routinely on a day-to-day basis does this. So I'm not suggesting that you should go and spend $20,000 or with a CBCT $100,000 to bring this equipment into your office because you want to create a surgical guide of $150. That's not what I'm suggesting. What I'm suggesting is that if you are interested to go ahead and do this, there are out there are companies, there are third-party laboratories that can go ahead and provide this service to you for a very nominal fees, at least in the States. In Guatemala, I'm not sure, but I believe that UFM, the last time I spoke to Dr. Kayarga, and he can correct me if I'm wrong, that I'm not sure if the outside dentists can send their cases for UFM to produce and send to them. So, you could chime in if that's not true, but in any event, there should be companies that will go ahead and provide you. So don't wash your hand and say, guided surgery is not for me because the equipment is too expensive. You really don't need this equipment. The only thing you need is how to know to plan the cases. And that's what we're going to go ahead and talk about. So as far as the immediate load consensus is concerned, just going back to that, there were multiple consensus in 2006 in Switzerland and ITI, third consensus in 2003, and again in Barcelona in 2002. And Esposito has also a paper and a consensus on the immediate load in 2007. So let's just quickly review the definition from all these consensus of what does immediate loading really mean. So the immediate loading is the restoration is placed in occlusion with the opposing dentition within 72 hours after implant surgery. That means if the patient walks into your office, you do the surgical procedure, you take an impression of the patient, you send it to the lab, and a patient comes up to 3 days after surgery to get their temporary installed on the implant that you just placed, that would be considered as an immediate load. Okay, up to 3 days, all right? Now, early loading would be a restoration is placed in occlusion with opposing arch after 72 hours to 2 weeks. Now, if you want to go ahead and wait for whatever reason, and you want to give the implant a little bit more time, up to 2 weeks, it would be considered as an early loading. Now, the conventional loading is a restoration is placed on an implant after 3 to 6 months after the healing. So that would be our regular bread and butter implant dentistry, where we place an implant and we restore it after however months we think that a patient needs for the healing. So, now the last portion is the non-functional immediate loading, and immediate restoration is the restoration placed within the day of the surgery to up to 72 hours after implant placement, but not in occlusion in opposing arch. So most of the cases, I want to say 85 to 90% of the cases that I do is that. And those are the cases that you work on an aesthetic zone, and you basically place the temporary, you take it out of occlusion, and you tell the patient, please do not bite, please do not use, please do not function, and just leave the area alone. And that would be considered as an immediate provisionalization versus the immediate loading. Because, and we're going to discuss why we do that on single cases, where if you have multiple cases, then you're a little bit more safer, because now the implants can go ahead and share their loads, so they can go ahead and be together. Versus when it's a single case, it's much, much harder for an implant to, or you'll be asking too much on these cases. So now, again, going back to a decision trees that you have to go ahead and come up with and decide, you know, what are your criteria? What is the patient coming in for? The etiology, the condition, the compliance, obviously finances, those are important. Am I making it removable? Am I making hybrid? Am I making a, you know, fixed bridge? What are the options? How many implants I place? You have to create a system where you eliminate all the other options and you come down to a final result for your particular patient who's going to be coming to you. So that's very, very important to go ahead and do. So those are the options that we have right now. So let's move on. So why do any information? Why should we do an immediate loading? So these are a few reasons why a patient needs to go ahead and get an immediate loading. So for example, an aesthetic zone consideration. I can manage that, you know, better if I am taking out a tooth and I can go ahead and place an implant at the same time. There are papers on that where you know, whether you would lose as much bone if you simply go ahead and bone graft it and come out versus putting an implant in there. So there are consensus of losing less bone on that. So immediate satisfaction for the patient. You know, they walk out, they come in without a tooth, they walk out with a tooth, they come in with a broken or infected or whatnot, and they walk out with a tooth in their mouth. So they're very, very happy. Obviously, social reasons. Patients don't want to walk around missing the tooth. Patients don't want to go ahead and go to parties and whatnot, not having a tooth, and they feel embarrassed about that. Patient's acceptance of treatment. That's very, very key, because you need to go ahead and don't look for a second in the financial aspect of it, but what you think is the best for that particular patient. So when you are presenting this case, you need to go ahead and tell the patient what their options are. So if you can do an immediate load, give the patient that option. Do not hold back because you don't feel the patient is going to go ahead and go for it. Few surgical sessions. Listen, if a patient comes in and you take out a tooth, do a bone graft, goes home, comes back, place an implant, that's surgery 2. Goes home, comes back, uncovery. Goes home, comes back, starting the teeth. So now you are multiple visit in the office. It takes too much in your chair time. If you can do it in one session, then that is a plus. Psychological reasons. If you have a young woman who's, for some reason, something happened to the front tooth, that becomes a very psychologically damaging situation. I'm going to tell you, my sister fractured a tooth number, a lateral incisor in the maxilla. And she came to my house on the day that it happened, sobbing and crying. And she's younger than me. And she just was completely, you know, psychologically very much affected by it. So that's very, very important how to go about, you know, that psychological, very important. So functional consideration and the soft tissue management, all those things, these are a few things that you could go ahead, and I'm sure you can think of other things to go ahead and put and say, why not? Again, a decision tree is why, what, how, which, you know, what am I going to go ahead and do? Why are we doing this? What are we going to go ahead and do? How are we going to approach this? And which are the decision trees we're going to go ahead and take for the patient when he walks into your office with the fracture in incisor tooth, where it's in an aesthetic zone, and those are the decision trees that you have to go ahead and kind of put together yourself. Now, to eliminate of what we talked about with the decision that we have to go ahead and make, you have to create a risk assessment. Now, the risk assessment, the goal of the risk assessment is to identify the patient for a specific implant treatment and put away the negative goals, the negative criteria versus the positive criteria on the patient. Now, that goes with any implant treatment, not just immediate loading, okay? Now, for the regular cases, you have certain risk managements and a risk assessment that you have to come up with. And then you have on a immediate loading, there are added risk effects. Let's look at this a little bit more carefully and understand to see what I mean. Now, in general, a patient walks in and wants to go ahead and get an implant. What are the risk effects and the risk assessment that we have for that patient? We take a look at the medical issues. Okay, we take a look at the periodontal problems. We look at the oral hygiene of the patient and an occlusion. Okay, so these are your risk assessment for the patient that comes in just for a regular implant treatment. Now, that also can go ahead and be on your regular dentistry. It doesn't necessarily have to be for implant specific, but you could go ahead and plug this in any aspect of implant of dentistry that we do. So I want to bring your attention to, I don't want you to take a look at the entire arch. This is a little bit too busy, okay? But this is talking about the immediate loading versus conventional loading. And then on top, you have 1 year, 2, 3, and a 5-year follow-up. Now take a look at the implant survival rate on an immediate loading, and take a look at the implant surviving rate on the conventional loading. So I just color-coded them so you can go ahead and compare between year 1, year 2, year 3, and a year 5. You could see those numbers are pretty much similar, okay? There's not much difference between these numbers, okay? So this article was published in International Journal of Oral Maxillofacial Implants, okay, in 2014. So take a look at this idea. Now this is for a single tooth loading, okay? Now let's move on. Take a look at a full arch loading. You got the immediate, you get the conventional, okay? Maxillomandible, maxillomandible. Now we're breaking it up to 2 sessions, 2 areas of the patients. And then you look at the implant survival rate. Now, immediate loading is on the first 2 columns, and the conventional loading is on the second columns. Again, I color-coded those numbers so you could compare the blue with blue and the green with green. Again, very, very similar together, okay? Now, full arch loading on the overdenture. Now take a look on top, immediate loading, splinted, conventional loading, splinted, okay? Maxillomandible, maxillomandible, and the implant survival rate. Look at the blue and the blue, look at the red and the red, and you can again see that these are similar. So at the end of the day, looking at these charts, what does that tell you? It tells me that when I place an implant conventionally, I get the same result as if I decide to go ahead and do it immediate loading, correct? Would that not be correct from just looking at this, research that was done? So why are we doing? Why is it when you place an implant and wait for it to heal 3 months, 6 months, it's the same survival rate as if you go ahead and give the implant the tooth the same day? So the answer to that question is that this charting and this situation is slightly skewed, and this research is slightly skewed. Why? When you go ahead and the patient comes into our office and they want to get an implant, I want to say today, 99% of the patients get an implant. We do not turn anybody away. We don't tell anybody, you know what? No, you're not a candidate. Very, very, very seldom, unless a patient is really medically ill and there's a big problem with them. Otherwise, we do not reject the patient. Versus when it comes to immediate loading, now we scrutinize the patient a little bit more. We ask the patient, do you have diabetes? Do you have this medical problem? Do you have a parafunctional habits? Do you grind your teeth at night? So those issues now become a factor whether I want to go ahead and pursue an immediate load for that particular patient. So when you're looking at these numbers, the number on the conventional cases are all patients who walked in, as opposed to ones that are on immediate load cases are cases where I have decided whether the patient is going to be a right patient for immediate load or not. That's why these two numbers are very much similar, because we pick and choose our immediate load cases, but we do not do the same on a conventional cases. Is that clear? Excellent. Let's move on. So one of the things that you're going to deal with is immediate load on an aesthetic zone, because I want to say most of my cases, 90% of them, are cases like this on this picture that you see, that these patients fracture a tooth, there's an infected tooth, there's a failed endo, there's a fracture, whatnot. So all these things are the criteria. Now, immediate load in aesthetic zone more often involves a non-restorative tooth that requires atraumatic extraction. So one of the things that I wanted to go ahead and bring home to you is it takes me longer to extract this tooth than to go ahead and place an implant and get the implant ready for immediate load. Because take a look at that soft tissue, how nice and healthy it is around this particular fractured tooth. It's very, very healthy, and you don't want to crush that soft tissue. And we're going to go ahead and discuss a little bit more about how to manage the soft tissue in an anterior area, so you will not, and some instruments that will go ahead and help you with that. Most commonly, tooth is fractured for present with a failed root canal therapy. Now, I see more and more today teeth that have a post inside them in the anterior area where now there is a fracture on it, and most definitely the fracture really comes most of the time at the tip of the post within the root of the tooth. And you could sometimes see it very clearly, sometimes you cannot, and the patient comes in and complains in pain and percussion. So those are the cases that I see most frequently today, and that's why when I do any sort of restoration, I'm shying away more and more from putting a post if I possibly can get away from putting the post. So one of the immediate loading issues that you're going to go ahead and deal with is a reduction in waiting time. The patient doesn't have to go ahead, and wait as long, okay? The other issue is high risk of infection. One of the big problems of immediate loading is that now you're combining and you're doing multiple miracles at the same time. So obviously your risk assessment or risk criteria goes much, much greater when you are doing it that way, okay? And obviously, without a doubt, most of the time, I want to say very, very frequently, close to 90% of the time, you need to go ahead and put bone graft to fill up the space where you are placing the implant. And I'm going to go ahead and tell you why, not necessarily so much about adding more bone, but a little bit more about stability of the implant. So you all have heard the concept of a bone set the tone. And that's really one of the things that we have, in implant dentistry. And it's our bread and butter in the success of our implant. How much bone you got. If you don't got, can you go ahead and create? So basically that's, one of the biggest criteria of what we are talking about. So on immediate loading cases in the anterior area, like what we're discussing, okay? So 75 to 90% of the time, the implant needs to go ahead and get that bone graft placed in there, okay? Obviously, depending, there's a article about what the distance should be so that you have a protocol to go ahead and follow. If it's 2 millimeter or higher, you graft. If it's 2 millimeter or lower, you don't need to go ahead and graft. But I have a, even with that less than 2 millimeter, I like to go ahead and put some bone in there, and I'm going to explain to you why I do that. So the graft, the purpose of the graft is to stabilize your implant, okay? That's what it's trying to go ahead and do, because if you leave this area, as long as the tissue is not covering your implant, as long as you're covering the entire portion of, can you see my marker right now? I'm moving. Okay.
Yes.
Okay. So as long as you go ahead and put, let's say, if I don't want to do an immediate loading here, and I put one of these custom healing abutment, and I cover the entire area, if you leave the space open, that will go ahead and fill up, okay? And if that's the case, what do I need this graft for, okay? So this graft right now is in here on a case with an immediate loading, is to go ahead and stabilize my implants. So I will not, if there is any micro movement, and what kills implant is a micro movement. Somewhere between 100 to 200 nanometer of movement will go ahead and create an invagination of the soft tissue along the body of the implant. So if you do not put this in, and a patient somewhat puts a little pressure on the implant, all of a sudden the implant will go ahead and move. The minute the implant moves, obviously we all know the case is done. So therefore, not only I'm putting it in here because I want it for the purpose of the bone graft, because this distance is very, very grave, but also because in case the patient somewhat functions on the implant, this bone, and I densely pack this bone. I don't pack it like your regular bone graft that you do when you are extracting your tooth, that you have to go ahead and go with a light touch to go ahead and tight it firm. But I really pack this hard, very hard, because I wanted to go ahead and prevent this implant and stabilize this implant. So the bone is also going to go ahead and create a soft tissue support. Obviously, we fill it up now all the way to the top area of the free gingival margin area. So you could go ahead and get a little bit more support from that. And the bone will create a higher torque value for your immediate load. So the minute you're packing this, and I'm going to teach you a technique how to do it to get even better stability and better condensation of this bone on one of our cases. So everybody knows that the implant is being placed, especially in the anterior and aesthetic zone. You have to consider the position, the 3D position in the jaw and in the area. Now we're going to go ahead and talk about different anatomies, what you should be expecting, and that's why it's very important to go ahead and have a Cbcp so you can see what you're looking at and whether that particular patient is going to be a candidate for an immediate load. So generally speaking, this was very much being done, and unfortunately, I do see this still being done. A lot of patients getting this kind of implant placement, where implant is exactly where the incisal edge of the tooth is. Now, that's not a problem. I have no problem with patients getting cemented cases, although there is a way to go ahead and create a safer cementable cases. But what I'm worried about is the thickness and the anatomy of the premaxilla and how much damage a patient is going to incur if this implant placed in this particular position based on a patient-to-patient cases, okay? So I call this rule 1, 2, 3. 1, or you should really say 1.5, is the distance from mesiodistally to the tooth. 2 is buccal lingually towards the lingual portion, 2 millimeter towards the lingual portion, and the 3 is 3 millimeter depth from the CJ of the tooth next to it. So that will be a perfect location for an aesthetic zone case where you can go ahead and put. Sometimes you can't based on different criteria, but if you can go ahead and follow this protocol, you will have a success.
Dr. Termechi, can you repeat that again? The 3 rules?
So the 3 rules are, I call it 1, 2, 3 because it just sounds better, but it's a 1.5, 2, and a 3. 1.5 is a mesiodistal distance between a tooth and an implant. That's how much space you should have for that implant between the tooth and an implant mesiodistally. 2 millimeter is, because this is a 3D position. Now you have to say, where do I put it buccolingually? Buccolingually, it should be like this picture, 2 millimeter lingually than what the tooth used to be, okay? And then as far as the depth, which is the coronal apical position of the implant, it's 3 millimeter depth from a CJ.
Okay, thank you.
Not a problem. And I appreciate you stopped me because, you know, if you have any questions, don't hesitate to please ask or stop me. Now let's talk about some anatomies on a premaxilla, which becomes a very big issues when you come down to your immediate loading or even placing your implant in the aesthetic zone. I'm not even talking about immediate loading at this point, just in general placing the implant in the correct position, okay? So the class 1 is a tooth centrally positioned within the ridge, and then there is 2 different criteria, 1A and a 1B, where it's a thick facial bone wall, which is more than 1 millimeter, equal or more than 1 millimeter, and then class IB or 1B is thin facial bone wall that you have less than 1 millimeter. So here is your class 1, okay? So the class 1 is that it's basically sitting in a correct position where the tooth is supposed to, in the center of the bone, but the only classification that divides in the subcategories is how much bone you have in the buccal. If you have 1 or more, it's a 1A. If you have 1 or less, it would be 1B. Now let's take a look at class 2. You have a tooth, it's retrocline, and that also divides to 2 different classifications, 2A and 2B, which is thick crestal bone or a thin crestal bone. And the look of that one is going to be like this. You see the tooth is retrocline coming inside, okay? And then you have the thickness of the bone varies between the 2. So that will be your classification 2. Class 3, the tooth is procline at this point, typically thick palatal bone, thin facial crest, and a thick facial wall apically. What does it look like? This is what you're looking at, okay? You have a very thick lingual area to the bone. You have plenty of bone beyond the apex of the tooth that you could go ahead and work with, but the tooth is slightly procline. Classification number 4 is tooth is facially positioned outside of the bone envelope. I am sure we all have seen this. And here is that classification. It's basically almost sitting outside the envelope of the bone. Okay? And a class 5, thin facial and a palate of bone and wall, which is probably one of the most difficult cases to go ahead and do and create a success. And here is that case. Because you are extremely, extremely thin in this area. And now you have to think to yourself, what's the best approach on a cases like this? Sometimes if you extract this tooth without placing an implant and just bone grafting, may possibly lose the window of opportunity for the patient to get any implant unless they do a major bone grafting. So this is something that you really need to go ahead and put a lot of thought in, okay, when you are planning your case. So to just review, class 1 is your regular cases, okay? Class 2, A and B, you could see the thickness of the bone in the buccal area. It's a little bit coming out and it's actually reclined towards inside the mouth. Class 3, it's actually going outside the mouth, but you have plenty of bone around it and the apical portion. Class 4, it's almost sitting outside the envelope of that triangle bone like Scott Gans talked about. And then obviously class 5 is a very thin bone on the lingual and on the buccal. Now, what do I see coming in to my practice? What is the most common one? Take a look at here, and you have class 2, okay, in the multiple research that was done, okay, in 1999. The class 2 is the most common one that walks into your office, okay? Then you have class 1, and then the next one is class 3, actually. The next one is class 4, and the next one is class 1 that walks into your practice. And then obviously, the very, very least is class 5, thank goodness. Because otherwise we'll be out of business, because these cases are now very easy to manage and to take care of. So those are the classification that you have when it comes down to the aesthetic zone and the consideration that you need to go ahead and have in order for you to go ahead and create a aesthetic harmony between the implant and the surrounding area. This is different criteria and the different osteotomy points that you can go ahead and make to create a harmonious situation. The blue line, I would say, are the cases where it's really for the best, but you're able to go ahead and do them mostly with a cementable cases. So you may have to go ahead and make for the patient a custom abutment and cement the cases. I don't want to tell you that you decide on, based on the literature and based on your comfort level, what you want to do when it comes down to final restoration for the patient, whether you want to go with the screw retain, whether you want to go with the cementable. I have colleagues of mine who would not touch anything unless it is a screw retain. And I have colleagues who love cementable because it makes their life easy. But you can be on both ends. They both have their own, pros and cons, if you will. And you can basically, you don't have to put yourself on that very narrow category and say to yourself, I will not do cementable or I will not do screw retain. You could keep yourself an open-minded, clinician. Where are you going to place the implant in the best location? And that's why, going back to the very beginning of the lecture where I said, when you pick an implant system, you better pick a system that gives you a really ease of use when it comes down to the restorative part, whether you're just a surgeon, whether you're a surgeon and a restorative guy. In any event, you need to go ahead and create that for yourself. And that's what you need to go ahead and do. So don't close your mind to saying, I will only do it cementable or a screw retain, but each one has its own criteria of how to go about doing that. So the implant position, generally in the past, we used to go ahead and place an implant dead center. And a lot of people tell me, I think the immediate implant placement, right now we're not talking about loading, we're talking about placing the implant in the correct location. So it was very easy. People say, I'll take out the tooth and I put an implant at the apical portion and I go just beyond the apex and I put the implant in there. That's the easiest way to go about doing that. Take a look at the picture to the left. That would be your placing an implant on a central area where the apex of the tooth is. Versus the correct location of the implant is the image to your right side. That will be the correct location. Now, when people tell me it's easier to do it because they end up on the criteria on the left side, that's what they end up placing their implant in. And I myself, I'm guilty of it as well because this is very technique sensitive. And there are times I make my osteotomy and it looks like the right picture and then it ends up being a left picture. And we're gonna discuss why that happens. But that is how it is. And I tell you 90% of the time, the implant does not go where the tooth used to be. The implant does not go where the tooth used to be. So if you are doing an immediate implant placement, that makes it very difficult because now you have to guide yourself and your implant to a different location and you have all this space to fight with. So your implant will not jump to this area. So on a 3D position, we used to place an implant dead center. We used to put it on the crest of the bone. That's what we used to do. Another thing we used to go ahead and do is, again, this is the image of putting an implant further back, but putting it right by the crest. Okay? Another one was, we thought that the bigger the implant is going to be and the more space you eat of the extraction site, it will be the best for the implant, right? The wider the implant, the stronger the implant, but that did not turn out to be the case because generally speaking, cases like this, you will see in your office where patients come with a gray area on the buccal surface of that implant, okay? So if the patient has a very thin bone, very thin tissue, all of a sudden you see this grayness of the implant. And generally the strength of the implant today has nothing to do with the implant itself, but it has to do with the bone that is surrounding it. Okay? So the more bone you have around your implant, the stronger your implant will be. I want to show you a case that I have done, okay, 14 years ago. 14 years ago, this case was done. Okay, patient came in. You're looking at a Straumann implant, tissue level, 4/8 by 12, strong tooth, strong implant. I take out the tooth, I put an implant in there, and I immediately load the patient. Okay, now the photograph you're looking at is 14 years later. So you could see that the bone has held up pretty nicely around the implant. Okay. The tissue is very, very healthy. You could take a look and see the zenith of the tissue up here is pretty nice. Okay, there's no collapsing of any sort in this area. Maybe slightly, but not that much. But now take a look in here. Take a look and see what happened here. And this is one of the things that we are learning as we keep on going in implant dentistry of how to go ahead and prevent this, because this patient had plenty of bone and plenty of soft tissue. And take a look and see how nice and thick keratinized tissue she's got. I'm going to show you a before. Okay? This is a before picture, and this is a 14 years, 15 years later. What happened here? Now, I want to bring to your attention something else that Arnold Weisberg has a research and a paper done on it. Take a look at the incisal edge of the adjacent tooth. Look at my case in 2003. Look at the case now, in 2018. This is 2 years ago. What happened here? Did the implant get shorter? Crown is the same. Everything is the same. What happened here? So we know that there is an adult movement of teeth, okay, in all cases. I'm just going to go back for a second, okay? One other thing that I want you to go ahead and take a look is take a look. Oops, I apologize. Sorry. Take a look at this picture. The tooth looks like it's coming out a little bit more facially. Large space on the distal of a central incisor, number 8. It's hard to see from this picture, but I'm not sure if that space was there. But in any event, teeth do grow and then implants don't. That's one of the challenges in the aesthetic zone that we have to go ahead and address. But what happened here? What could have gone wrong? So I have a theory of what happened. This is what happened, okay? The difference between a convexity and a concavity of a final crown, okay? In order, and this is again another Arnold Weisberg's paper where it tells you that in order for you to go ahead and not disturb the soft tissue, I was always on the impression that would be a short term, but in reality, it's translating to the long term, that in order for this soft tissue to not shy away and go, we need to go ahead and create a much thicker soft tissue today than we knew we had to. In this particular case, the concavity of the tooth, whether it's a temporary, whether it's a final crown, even in my case, in this particular case, where a patient had a very thick carinized tissue, it didn't show up right away, but as time passes, tissue just kind of give up and recedes. So this could be one of those reasons, because patient had plenty of bone, everything was according to how it's supposed to be, but I believe that has something to do with a convexity or a concavity of the crown that I put in there, and I put a concave crown to try to go ahead and support it. So this issue becomes an issue if the implant is not deep enough. Because if you do not have depth of implant within the bone, you will have very little area to go ahead and play with to create this concavity. Okay? So here is her smile in 2018. Okay? So thank God, you know, it doesn't show on the smile. And maybe she could have smiled a little bit bigger. Maybe you would have seen it. But in any event, you know, it's still in function. And, you know, again, going back, is this a success, or you call it not a failure, but, you know, something less than what we anticipate to go ahead and try to get in aesthetic zone. So here's another case on a cementable, just to let you know, immediate load case, a patient, I placed an implant. Again, it didn't work out.
Dr. Termechi, can I ask you a question?
Sure.
Going back to the last one, the reason the tooth shows as higher is because the other teeth erupted more, or is that, what is the reason that number 8 is longer than number 9? Is it because the tooth moved buccally?
Correct. Not because the tooth moved buccally. We now know that there is a adult growth still continually going on in a patient, where we don't realize it when it's all natural teeth, because everything moves in together. And we don't know the reason. The etiology is not known why this is happening. But once you place an implant and now the implant is ankylosed and an implant doesn't move, now this issue becomes a little bit, especially when you're having a single case, now this issue becomes more prominent and you're able to go ahead and see it, and you can see here a little bit. But even the patient didn't know.
No, I got it, because
Okay?
I've had a couple of cases like that, and we were dumbfounded. We didn't know what the reason for it was.
Correct.
So now this actually is very helpful. Thank you. They actually explained that to me. Thank you.
Not a problem. So here is a cementable case, okay? Again, implant was placed. I did an immediate load. I did it as a cementable case on a solid abutment, and then finished it and went on with that case. Now, here is where you generally want to be in an aesthetic zone, okay? You want to go ahead and create like that 1, 2, 3 idea that I just gave you, okay? It's 1.5, in this particular case is a 2.5 millimeter distance from mesiodistally to the tooth. But buccolingually, that is a very, very critical space that you need to go ahead and create. And obviously, you can go ahead and fill up your bone all the way to the very, very top of gingival margin to support the tissue as well. Okay. So this is a little bit of a busy slide, but I wanted to go ahead and bring home to you an understanding that is extremely, extremely crucial to the implant dentistry when you place an implant next to a tooth. So the distance between an implant to the implant, it should be 3 millimeters. So if you have 2 implants adjacent to each other, you want to go ahead and create as much distance more than the one that you have for the tooth to the implant, okay? Due to the lateral bone loss of a 1.4 millimeter next to the implant. So there's a research done by Tarnow and Esposito that shows you that you get, take a look at the picture on the x-ray on the right side, okay? You have to expect or anticipate that type of a bone loss because you're going to go ahead and lose that kind of bone. Now, when you see that kind of bone being lost, take a look at the very thin bone that's sitting on the root of the tooth. Now, if you have an implant, this bone will hold tight. Okay, if you keep the distance of the implant to the tooth, that bone will hold. If you are any closer to each or the other, you may take a chance of losing that bone. And as we said, bone set the tone, correct? Especially when it comes to the soft tissue. So therefore, you need to go ahead and very, very carefully, strategically place this implant in a correct location to respect this space between the tooth and an implant. Now let's take a look at the other one, okay? The distance between the implant and the tooth should be 1.5. I apologize, this is for this particular, and so you will not go ahead and lose this. This picture, take a look at this bone, that peak of bone. If this space is any shorter than a 3, then you will go ahead and lose this peak of bone. You could see it a little bit clearer on this picture. Okay? So the point of keeping the distance between the implant is to prevent the loss of a 1.4 millimeter next to the implant, that bone that you're going to lose. You want to prevent that to reach this peak. If you have this peak, you can create a pseudopapilla. Not a true papilla because that would be next to a tooth, but you could create a pseudopapilla. All right? So, going back to the immediate loading. The reality of the immediate loading that when you're doing clinically, implant will end up to be longer. So anticipate, treatment plan, have the correct armamentarium, have the correct size implant. If you're looking at your implant, the tooth, and it's 10 millimeter, you need to go up to 13 millimeter in order for you to go ahead and combat that position. Okay, implant will move into the path of least resistance. That's why every step of the way, I try to go ahead and put a special paralleling pin in, and I will use, even if I'm not doing computer guided, I will try to go ahead and put some sort of guide to allow me to verify each osteotomy after osteotomy is done. 2 millimeter, 2.5, 3. So I can put a paralleling pin. If your implant system doesn't have a paralleling pin, use the burr that you just used. But I keep on putting my OmniVac guide or whatever guide that you make back and forth in the patients after each osteotomy. And also at the very, very end, when I place an implant. Check yourself to see if you are placed the implant exactly where you made your first osteotomy. You want it to be easy, you could do computer guided all the way to the very, very end. You place an implant in there with a guide and it goes right in, okay? Be ready for a backup temp, okay? Don't be cocky. Do not try to go ahead and sacrifice your implant. If you do not have a correct torque on that implant and it's not going in the way you want it, or you don't feel secure about the implant, don't jeopardize the implant and be ready for a backup, whether it's a Maryland bridge, whether it's going to go ahead and be some sort of removable prosthesis, but don't let the patient drive the treatment. And I never promise the patient that they're going to have an immediate load. I said, we're going to try if we can, we'll do it. Temporary color mismatch. Every case that I have done, especially, it's difficult as it is to send the case to the lab and try to convey a color to them on a permanent. Same thing with temporary. Even if the temporary looks fantastic and great, by the time you are done, you will see a great mismatch between a temporary and a tooth, because it's just the handling and the relining and so on and so forth. It basically ruins the gloss and the color that originally possibly had, okay? The other issue in implant dentistry obviously is, as we know, like bones set the tone and tissue is the issue. So that falls on the category of aesthetic. The bone falls on the category of function, and the tissue falls on the category of aesthetic, of how we're going to go ahead and try to recreate, or I shouldn't say recreate. Most of the time, we want to try to go ahead and maintain rather than recreate, okay? Because if you follow a protocol, you could hold on to your soft tissue, and now it makes it so much easier for you and the patient and the cost and the finances and hours and office visits, as opposed to trying to go ahead and build it back after you lose it. Okay? Now, one of the most important part of the entire process of aesthetic zone, obviously as far as the tissue is concerned, is to understand the biology. Obviously, we all know that the papilla is essential to an ideal aesthetic result for the patient, right? But take a look. Number 2, supracrestal fiber holds the papilla coronally on the tooth. Those are the fibers that basically holds the papilla in place. Periodontal disease can go ahead and ruin those fibers. And you could have recession because of it. You could lose papilla because of it. Okay? Now, third one, no supracrestal fiber is found around the implant. That is the big contrast, and that is our fight with an implant. Because we have those supracrestal fibers on a natural dentition, and we don't have it on an implant, that's where all this protocol, we could have just create and hold on to those supracrestal fibers around an implant, and life would have been so much easier. And everybody knows about the Tarnow rule of 5 millimeter, okay? So if the head of your implant is 5 millimeter to the contact point to the adjacent tooth up to the 5 millimeter, you basically you hold on to your papilla as much as 98% of the time. So that's something you need to go ahead and check every time you place an implant to measure the head of your implant in adjacent to the tooth and the contact point that you have to the adjacent tooth. And then a mean vertical height between the implant to implant will be 3.4 millimeter. Okay. Here is another case. Again, take a look. These are all my old cases where all cementable. Okay. A patient had a tissue level implant. This is a solid abutment, no modification on an abutment, and the crown was made. And just take a look at the soft tissue. Okay? Now, going back to what we discussed as far as the movement of the teeth. Here, it did not move. Nobody knows why the tooth decided to go ahead and move. But this patient, when I placed an implant 12 years ago, she moved to a different state, and then she came back, her crown was loose, she called me up, she came in, and I was so thrilled to go ahead and see her just to take this photo after 12 years of an implant placement. The restorative doctor did a fantastic job on almost matching those shades and the crown, and looks great. I would have put a little notch on this guy just to mirror image this crown here. I don't know, that would just be me. But in any event, that's the difference between the implant and the tooth. But yet, if you follow all those protocols that we said, the distances, the proper placement in a 3D position in the premaxilla, you may come up with this situation. And of course, look at the soft tissue. I mean, this thick keratinized tissue is beautiful. The texture is slightly different around the implant than the natural dentition is, but ultimately, you know, I'm now focusing and trying to go ahead and find a difference between these two, but it's pretty good. Okay, so that's, as long as we create that issue, and going back to the last slide where we talked about the papilla and the supracrestal fibers, okay, if you keep this guy away enough, this papilla will follow the natural dentition. Now, if the patient will lose this tooth and now will place another implant, that's going to be a different story, because now you're taking out the source of support for this papilla. Now, this area will be completely a different story. So, what are the benefits of doing an immediate load? Okay, just a few of them on top of my head. A fixed temporary prosthesis, the patient's gonna walk out, which is gonna make them very happy. Patient satisfaction, it reduces chair time in your office. It expedites the treatment, it reduces treatment time for yourself, support a hard and a soft tissue in the aesthetic zone, and a financial advantage, because you're basically providing almost 80% of the work in day one. So, and why not? Why not do an immediate load, okay? It's a close relationship to anatomical structure. So all of a sudden, you're next to a, let's say, a mental foramen, a sinus, a nasal cavity, whatnot. And because of that, you cannot go ahead and put a long enough implant to get a good stability of an implant for a good support. So therefore, you have to opt out of the immediate load. Active infection, if the patient is like oozing, you know, purulence and exudate, you want to go ahead and not attempt doing that because you probably won't have enough bone. Lack of buccal wall in that area, lack of bone beyond apex, and it's very, very technique sensitive. So if you're not familiar with it and you are not sure, what to do, then maybe you want to go ahead and opt out of the immediate load. So any questions before we take a look at the first case? I'm going to turn off the fan in the room. Give me 1 sec. No questions. Okay. So let's move forward and take a look at a case. Now from here on, we're going to touch upon different cases and whatnot. But here is a patient of mine. She is probably at this stage 84 or 5 years old. I have done all her implant cases in her mouth, and she comes in with a lower anteriors. And I generally like to go ahead and keep the lower anteriors for the older patient with just simple splinting and not take them through a vigorous treatment plan to go ahead and do anything. But in this particular case, you could take a look at these x-rays where, there's, the teeth are basically have given up, and it's very difficult to try to go ahead and maintain that for her. And they're very mobile and they're moving, so there's no point of keeping it. So this is the case that we did immediate loading with a computer-guided placement. So here is the patient's Cbcp. You could see a little bit of a bone loss in this area for this patient, but it's acceptable. In a patient that age, you really go ahead and expect that, and you can go ahead and see that. So I treatment planned the patient. So all these implants I placed for her, and she basically does not want to walk around with any removable prostheses. And this is going to be the next thing, the next project that we have to take up on her, you can see. But right now, she had pain, she had discomfort, so we had to go ahead and take care of this issue. So I did not make this guide. I sent it to a third party to go ahead and make me the guide. So they send me a report. I basically treatment planned it myself on the Blue Sky Bio planner because I want to know what I want to go ahead and place. And that's something that I need to drive to you today is please learn how to do this on your own and not rely. Obviously, a lot of these third-party companies who do these kind of work, they have lab technicians sitting there. They're really savvy and they do a great, great job. But they are not you, and the liability is not going to be on them, okay? The liability, and you sign something and that says the liability is on you. You are the doctor who's going to treat the patient, and if anything goes wrong, you are it. Although they are there to protect you and they're there to go ahead and guide you how to go about doing it, but you need to take your time to learn this. So I send this case out for them to go ahead and make the guide for me, even though I can do it in the office, but this one I send out to go ahead and have done. So basically, we treatment plan it. They call me up, doctor, we have the case. Here's the picture, take a look. I call them back. I'm like, okay, move it here, move it there. So we come up with a consensus of where we want the implant, okay? In this particular case, I like a system that's keyless. And a keyless means this. Take a look at this image, okay? This is your burr, and the burr goes into the sleeve and it stops at this stopper, okay? Now, I can pick up a burr that gives me an 8 millimeter. I can pick up a burr that gives me a 13 millimeter implant on the day of surgery if I change my mind. Why? Because your coronal apical length of the implant, it's calculated within the guide, okay? That means you have an ability to change your mind if you wish. whether you want to go with thinner implant, if you see there's a mistake, whether you want to go with a longer implant, if you feel that you want, or a shorter implant, either or, you can still change your mind the day of surgery. Now, I like keyless because it eliminates another part in the patient's mouth. And there are some companies today that create still with the key, that you have to put the key inside. They put a master a cylinder inside your guide. You put a key in there. Each bird that's drilling in has a certain key that you go ahead and put in, and you drill. Now, the problem is that you have to use one hand to put the key, one hand to drill the bone, and then somebody has to hold the guide down, okay, because this is going to be a tooth-borne guide to go ahead and do. So that's why it's just another thing for you to go ahead and worry about, and I don't want to worry about that. The whole point of a computer guided is I did all my thinking before the patient came in. So to just give you an example, take a look at this image over here. This is a 13 millimeter burr that's coming in, but you see this portion is smooth, which means it's not cutting. So probably the crestal bone is right here all the way down. Not probably, it's for sure. That's where crestal bone is. This is probably all the soft tissue that this burr has to go through in order for you to go ahead and be able to drill at the crestal bone. Here is another image. You can go ahead and take a look. And here is an image of the stopper that you can go ahead and just go all the way to the end. So a patient comes in, we extract the tooth, we'll clean up the area, we'll place the guide. Now, most companies, or when I make my own guide, create these windows. Take a look at these windows. You see these windows that there's nothing there. There's another one here, there's another one here. These windows are basically to verify that the guide is sitting in a correct position. That means if there is any gap between the guide and the tooth, if you can get your Explorer in there, that means the guide is not sitting in all the way. Something is holding that guide back. Okay? So before you make any osteotomy, stop for a minute and take a look, and you may need to go ahead and make an adjustment. Guide would be just like if you were having a night guard placed in. You'd never put a night guard in the patient's mouth and say, that's it, go. You have to check the occlusion. You have to go ahead and make sure it fits. If it's completely seated all the way, you may have to make some, obviously this is a hard night guard. You have to make certain adjustment to those guides. But same thing with the guide. Don't be very sure that what you get from the lab is going to be exactly accurate to what you want. So you have to first, before you do anything, make sure that this guide is seated well, okay? And as far as the osteotomy is concerned, maybe you want to go ahead and step back. If I'm placing a 13 millimeter, maybe I want to go with an 8 first. Take an x-ray. If you're starting this fresh, take an x-ray, verify your position first before you move on to your final length of your implant. So this particular case, I'm pretty sure that this is what we want. I go to the measurement with the 2 millimeter burr, and I just go ahead and put it in. Now, another thing that I like to go ahead and do, I like to take an x-ray with those burrs inside. Okay, that's the best paralleling pin. The guide is stable, the burrs are inside the bone, they stay there, they don't move. I asked my assistant to go ahead and take an x-ray, and he did a fantastic job. Because it's a little bit hard with all this material sitting above the occlusal plane of that. Take a look at this image over here. You've got to make sure that you see this bottom out all the way to the bottom. Okay, and if you bottom out, Again, at this point, once you make sure that your guide is accurate, then you do not need to go ahead and worry about anything. You could just go ahead and zoom all the way. Just make sure you bottom it out. So pick your implant that you want. And if you are very, very careful. Now, another thing I want to tell you about the guide is please do not hesitate to remove it. Okay? Don't put all your trust in the guide. Don't hesitate to remove it. Don't hesitate to look at the parallel pin inside the bone. Don't hesitate to move the soft tissue to see what's going on, to verify yourself. But you need to do that once, and once you do it and you're happy, then you could go ahead and continue. But don't just wash your hands and say, I have a guide, it's going to go ahead and take me home every single time. Because sometimes the guide is not what you thought it will be. So obviously the success of our implant has to do with how much torque we get today, right? So just minimally talking, your torque, that Peter Worley had an article back in the 90s, the torque that you are looking for immediate load is 20 to 30 Newton centimeters. If you have that, then you're in good shape. But you can go ahead and take a look. Now we are a little bit spoiled. Take a look at the amount of torque that we have. It's almost 80 Newton centimeters on this case, okay? I can almost, if I was now worried about the soft tissue shrinkage, I could have just taken impression of this patient. If this was a case that I didn't have to make an incision, I could have just taken an impression of the patient, have the final restoration ready for this patient in 2 weeks. Okay, I mean, that's how confident I am on this particular case. I restored this case on an 84-year-old in 6 weeks. Just waited for soft tissue to heal. Why? She's 84 years old. How much can I go ahead and hold her off not having her teeth? Plus, at the same time, you want to eliminate as much time for this patient in your office. So that's why you need to go ahead and drive the case. That's why immediate load becomes a much, much more powerful for certain group of patients than others. And this is what you want to go ahead and be able to provide to your patients in your office, okay? Now, a precise placement of this implant, the guy did exactly what I wanted to do, and it delivered exactly where I wanted to place my implant. Made my life easier. Am I able to go ahead and do this without the guide? Absolutely. On an 84-year-old, would I rather go ahead and do all my work in advance before I can go ahead and, you know, bring the patient in? Absolutely. This case, from beginning to the end, took an hour and 15 minutes. Let's talk about the lab provisional, okay? One of the most important part of immediate load, if you want to go ahead and take a look, is a provisional. Now, one thing I'm going to go ahead and give you an advice. If you are sending a case out to the lab to make you a temporary, okay? They make you a temporary like you are restoring a natural dentition. Take a look at my temporary. You see it? I told my lab I'm placing an implant here, I'm placing an implant here. Okay? And you could see, why did I opt to have a cantilever? You see there's a cantilever here. There's an implant here, there's an implant here, and there's a cantilever. Anybody want to shout out why I decided? Okay, the reason I decided on the cantilever, it's a close proximity sometimes to the teeth. And if you're too close to a natural dentition, you will not have a parallelism that you want to your other implant. So in a lower anterior, where I have type 2 or sometimes even type 1 bone, I opt to create and have a cantilever where I can keep my parallelism between my two implants perfect. Okay? This is the case. Going back to the provisional, as a restorative doctor, you need to tell your lab to overbuild the lingual portion of this provisional. Really, really overbuild it. Because it's always easier to drill out acrylic as opposed to going ahead and putting more acrylic in. So have them do that. Because if I want to go ahead and have this case as a screw retained, I'm going to end up in this area, and all of a sudden I have zero acrylic beyond it. One of the criteria that you need to go ahead and pay attention to is your temporary abutment. There are multiple temporary abutments in the market. There are fully plastic abutments, okay, for temporary purposes. There is a fully metal temporary abutment from the beginning to the end, and then you have a mix of metal connection and a plastic body. All right? So which one is the best temporary to go ahead and use? Okay, these are a few examples of the temporary that we are talking about. They make them plastic because it's much easier to go ahead and prepare, and you don't want to go ahead and prepare the temporary because the metal just flies all over the place while you're doing the surgery. So that's definitely a plus. But what do I use? What's the thought process with this? So one of the things that becomes a big issue on an implant is the microspacing that's created if the temporary is not a perfect fit to the body of the implant. And if you have a plastic, that may create some, microspacing in those areas where it's a reservoir for bacteria. And as a natural result, if you have this issue, you will end up with a bone loss at the crest of bone, because that's the most sensitive part of the entire body of the implant and implant to the bone contact. So as you go ahead and obviously, and then just follow the whole, dominoes effects, the bacteria leads to the bone loss leads to soft tissue, the soft tissue leads to a poorer aesthetic result in your case. So when you decide to go ahead and pick a specific temporary, then it's best to go ahead and at least to have a temporary that does not have a plastic connection, but a titanium connection. Now, even in the cases like this where I have to make a prep on these cylinders, I basically go ahead and I do it outside the patient's mouth. I mark, and then I come outside and I do the adjustment. But I want to bring your attention to the temporary. Look what happened to my temporary. Isn't that amazing? It just completely shattered. Now I have these pieces of acrylic laminates that I need to go ahead and work with to create the temporary and reline. So it makes your life a little bit harder and more difficult. You got to tell the laboratory to build that area up. So take a look over here, see what I did. I picked up a paper clip and I just put a paper clip back there. Or if you have something else, you can go ahead, if you have a wire, the ortho wire, you can go ahead and use that. But I basically reline it in the patient's mouth. You can see the abutment. I didn't even make an adjustment to the abutment. And then I'll take it off, obviously, and I work outside the patient's mouth, and then I put it in. And here is the patient with a provisional in, okay? She was happy. She didn't want to go ahead and have anything removed, okay? So this is 2 weeks later, and the patient is healing. Now, I wanted to just kind of stress to you, look at the two pictures on each end, okay? When I do an immediate load, I don't touch the provisional for an extent of time that I want